Ms. Richards, you're going to deal with knowledge of the risk.
Yes, sir.
Now, today, just so that everyone knows where we will be in terms of timing, because we aren't subject to the witnesses giving his evidence, Ms. Richards will have her timing under control, I understand.
I hope.
So what we will aim to do is we'll aim to finish no later than 4:30. There'll be, again, 45-minute breaks in both the morning and in the afternoon. The afternoon probably a little bit earlier than it was yesterday, to divide up the afternoon rather better. 45 minutes to enable you to have the time to go safely at distance to pre-allocated seats for refreshment. So that's what we will do, so you know where you are and what the timing will be. Ms. Richards.
So if I can just start by explaining the purpose of today. Today is the provision of a chronological and historical overview of material relevant to the knowledge of risk of infection from blood and blood products. It'll be undertaken by showing contemporaneous materials, and those will be drawn from a range of different sources, government, scientific journals, correspondence, meetings, and so on, as well as media, and we'll be showing a number of documentary excerpts in the course of the day. The purpose of the presentation is twofold. It's to place relevant material into the public domain. The core participants have already been provided with copies of all the material that will be referred to and with a detailed chronology relevant to this issue. But the purpose of today is to ensure that the material or some key parts of it is shared with those who've not had the opportunity to work through what will be thousands of pages of material, and to ensure that the wider public is enabled to understand what was or was not known at various relevant times. The second purpose of today is to provide a backdrop to the evidence that's going to be heard from witnesses over the coming weeks and months, from clinicians in the first instance, and in due course from politicians, civil servants, and others. I should say what today is not. It's not going to be examining in any kind of detail what was known by a particular individual or a particular organisation, or what should have been known by that individual or organisation, nor is it going to be looking in any kind of detail at what was done in response to those risks. Again, that will be material that's explored over the coming weeks and months with witnesses. We're very grateful to core participants who have suggested additions to the material that's in the chronology. Some of that's been incorporated in today's presentation, but we would welcome any continuing suggestions, and the chronology can be updated with any additional material that core participants or indeed others think is relevant and can bring to our attention. So broadly speaking, the presentation falls into four categories chronologically. The first will be looking at the developing knowledge of risk of the transmission through blood or blood products of hepatitis from the 1940s through to the 1970s. The second is to look more particularly at the developing knowledge about non-A, non-B hepatitis in the course of the 1970s and knowledge of the seriousness of the condition. The third is then to look at the developing picture in relation to HIV and AIDS in the first half of the 1980s. And the fourth then picks up the picture going up into 1991 in relation to developments, the discovery of hepatitis C and some key dates and documents in relation to that. I don't propose, for the purposes of this presentation, to look beyond 1991, although clearly the years after 1991 contain much significant material, but those will be explored in later stages of the inquiry's hearings. And VCJD specifically will be the subject of a discrete hearing in due course next year. So I won't be touching on VCJD today. And the other point in relation to timing is I'm not quite sure how long today is going to take. If I don't get through the material that seems most important, we'll continue tomorrow rather than sit late. before moving on tomorrow to look at the actions of Professor Bloom and the Cardiff Haemophilia Centre. So there's no single right place to start, but I'm going to start in the 1940s with observations of jaundice in army personnel and its relationship to the vaccination against yellow fever. Henry, could we have, please, RLIT 40209? Now, this is a document entitled Jaundice in Army Personnel in the Western Region of the United States and its relation to the vaccination against yellow fever. It's the second of two papers published in the American Journal of Hygiene in 1944. But the events to which the paper relates focus on the high prevalence of jaundice in troops in the spring and summer of 1942. In circumstances in which the troops had been vaccinated against yellow fever. It is a very long article. I'm just going to go to a small number of points from it, but I'm very grateful to call participants who've suggested some shorter précises of this issue, and I'm going to give a couple of references. They don't need to come up on screen, Henry. It's for the benefit of others who may want to read about this issue. There are more recent analyses of this issue at RLIT 301238, RLIT 301234, and RLIT 301237. Those are all later documents that look back, but I'm focusing, as I said today, on contemporaneous material. Henry, could we go, please, to what I think should be page 39 of the document. I'm sorry, my apology. I'm using the internal pagination, so it'll probably be page 5 on the documentation you have. Thank you. So we can just pick up here a report in 1937 in England. We look halfway down the page, Henry, if we could have see the whole of the part. Thank you. England post-vaccination jaundice. In 1937, Findlay and McCullum reported that in the course of 4.5 years, they'd vaccinated approximately 2,200 persons against yellow fever and had observed 48 cases of jaundice occurring from 2 to 7 months after vaccination. And then if we look at the right-hand column, Henry, could you highlight the first 10 or 12 lines of the second paragraph, beginning Findlay and McCullum? Is it possible to highlight that in yellow? So it's easier for others to read. It's the previous page. Thank you. That's perfect there. It's much easier with a pen on paper. Anyway, those who are looking will be able to see what passage I'm referring to. So it refers to Findlay and McCullum firmly convinced that jaundice was not caused by the yellow fever virus itself. In a later report, 1939, they analysed in detail the various factors involved in this episode and came to the conclusion that the causal agent of the jaundice was a virus that had been cultivated serially in tissue cultures in symbiosis with the yellow fever virus, and that it must have been introduced into tissue cultures in association with human serum. So that's the key issue here, human serum, presumably derived from a donor who was either in the incubation period or actually suffering from a mild subclinical attack of epidemic catarrhal jaundice. And then if we could go, please, Henry, to... I'll try and give you the right references. Page 58 of the article, which I think might be page 24 of 73. Yes, that's it. And if we look down the bottom half of the page, please. So we can then, picking up on what had been observed in 1942, jaundice in the military forces in the United States and elsewhere following vaccination against yellow fever. As stated in part 1 of this report, information was received in March 1942 that in United States Army personnel, there was a considerable amount of jaundice, which appeared to be associated with certain lots of yellow fever vaccine used for immunisation. And then, Henry, if you could skip on, please, because there's a very detailed account of the investigation, which I won't go to pages 54 to 55 of 73. It's page 89 of the 89 of the internal pagination. That's it. Next page. So if we pick it up under the heading conclusion towards the bottom of that page, it's not yet been possible to demonstrate conclusively which of the various materials used in the preparation of yellow fever vaccine actually contained the agent responsible for the outbreak of post-vaccination jaundice. However, in view of other investigations that outbreaks of hepatitis have followed the injection of human serum alone, and also that it's been possible to transmit a very similar disease by direct blood or serum transfer from patients suffering from infective hepatitis to healthy volunteers, human serum falls under suspicion much more definitely than any other substance in the vaccine. And it's instructive to note, if we go to page 103, if you're using the internal pagination, Henry, or it's pages 68 to 69. Thank you. We see, if we go down to the bottom of the page, please, Henry, recommendation. We see that in the course of this investigation, the investigative team in April 1942 made recommendations to the Surgeon General of the Army to suspend the use of vaccinations in which human serum had been implemented and to use effectively different vaccinations. And that had the desired effect of stopping the particular attacks of jaundice that have been observed. Could we then turn from America to, still within 1942 and the war years, this country, and go to DHSC 01408_024, please. We can see this is headed Emergency Blood Transfusion Services Delayed Jaundice. It's an internal DHSS document, and it's a note of a discussion held in Dr. Taylor's room on December the 1st, 1942, with a number of doctors in attendance. Dr. Taylor said that recent investigations suggested that blood transfusion might result in delayed jaundice, and the meeting had been called to decide whether and how hospitals, maternity units and general practitioners should be informed of the latest developments on the subject and whether any preventative administrative measures were possible. And then Dr. Bradley gave an account of the history of the appearance of jaundice believed to be due to the introduction of human serum. And we can see from this that going back to the 19th century, there had been issues of concern as to the connection between human serum and jaundice. So we have 1885 in Bremen, 191 cases of jaundice followed the use of humanized lymph. 2, measles convalescent serum. A batch of serum used on 109 children resulted in 41 cases of jaundice and 8 deaths. On another occasion, 57 cc injected in 14 children gave 6 cases of jaundice and 1 death. And that was picked up by and considered by the chief medical officer of the time in the late 1930s. We then have the reference to the yellow fever vaccine, reports of jaundice in Brazil, in the American forces, that's the material we've just been looking at, reference to convalescent mumps plasma with 87 cases of jaundice. All the above vaccines, etc., contained human serum. And then we have reference to blood transfusion. The first case of jaundice following a transfusion was notified from Wolverhampton. Subsequently, 8 cases of jaundice resulted from 35 transfusions of serum given for peripheral vascular disease. And then it says this...
36, I think.
I'm sorry, yes, 36, apologies. In all, 13 cases of jaundice apparently resulting from transfusion were known so far to have occurred in England, but it had not been possible to plan any follow-up of transfused patients. Not possible to rule out the possibility of natural causes, but certain information suggested there might be a distinguishing clinical picture in the case of jaundice caused by introduction of human serum. And then if we go over the page, we can see reference to certain measures having already been taken, discussions with the Medical Research Council, Dr. Parton, Dr. Project, and the blood transfusion officers. We're told that the MRC Transfusion Committee had convened a small ad hoc subcommittee to inquire into transfusion jaundice. And I emphasise this is in 1942. With the exception of the CMO's reports in 37 and 38 on the measles case, none of the known cases have been published. But Dr. Bradley has now been asked by the CMO, the Chief Medical Officer, to publish in the Lancet a memorandum which he'd prepared on the subject with a view to bringing it to the notice of blood transfusion officers and general practitioners and urging them to record batch numbers of transfusion materials used and any cases of jaundice resulting. And then if we just go down to the bottom of the page, it was agreed that the following action should be taken. A, Dr. Bradley agreed to word his memorandum for the Lancet in such a way as to prevent unnecessary alarm. He would stress the importance of recording the batch number of materials used in transfusion and of reporting cases of jaundice following blood transfusion. There's a reference to general practitioners being asked to report matters to the hospital. And then after the publication of this article, the Ministry would issue a DGL drawing attention to it and asking hospitals and maternity units to maintain case records, do all that was possible to follow up patients who've been transfused and report any cases of jaundice to the supply depot. The DGL would also stress the importance of making a senior officer in each hospital responsible for transfusion. So it can be seen that at a senior level, this was regarded as a significant and important issue in 1942. The memorandum that's referred to there, that's going to be published in the Lancet, we have at NHBT 5091_011. Please, Henry. And we can see the date of its publication is January the 16th, 1943. It's published in the Lancet. The title is Homologous Serum Jaundice, and it's a memorandum prepared by medical officers of the Ministry of Health. I won't go through the detail of it, but if we could turn, please, to, should be the 4th page, Henry. That's the one. We can see a heading towards the bottom of on the left-hand column, transfusion hepatitis. Reference is made to various incidents. And then, if we can pick it up on the right-hand column, Henry, the paragraph beginning the appearance of this phenomenon. Don't know whether it's possible to highlight that. It's about the 5th paragraph down, please. So the appearance of this phenomenon, that's the hepatitis, jaundice appearing after some form of receipt of human serum, was anticipated at the Ministry of Health, where information had previously been received of another grave case of jaundice following whole blood and plasma transfusion. On August the 13th, 1942, a meeting of the principal blood transfusion officers was called to inquire inter alia whether this was an isolated case or whether transfusion was more frequently followed by hepatitis. Transpired that not until August the 12th did the cases in the EMS hospital, that's the particular cases that are being looked at in part of the memorandum, come to the notice of the transfusion officers. Since then, the condition's been observed at 3 other hospitals. The total of known cases following transfusion is now 12. It must, however, be remembered that no systematic follow-up of transfused patients has been attempted, and that since an association between transfusion and late jaundice is unlikely to be recognised spontaneously, it is not to be expected that such remote sequelae would be brought to the notice of the blood transfusion officers. And then this sentence, for this reason, it cannot be assumed that whole blood is innocent or that plasma is likely to be less icterogenic than serum. And if we go 2 pages further on to the last page, please, Henry. Under the heading comment, this Ministry of Health memorandum concludes as follows. The examples of homologous serum jaundice collected in this paper make it clear that the subject is one of major importance. Our understanding of the mechanism has not advanced since 1937, when measles serum jaundice was first described. One conclusion is now, however, evident. Any doubt as to the reality of the association is removed by the frequency with which hepatitis has followed the injection of human blood products. The probability that further cases will occur, particularly after transfusion, must be faced. So that's the Lancet Ministry of Health publication, 1943. Can we then please have up on screen, Henry, DHSC 01 508 _ 051, please. It's not the easiest document to read. I have a handy translation. It's entitled Prevention of Homologous Serum Jaundice, Memorandum to MRC Jaundice Committee on Administrative and Field Aspects, and it's authored by Dr. Bradley. The date is the 20th of June 1944. And there are just a couple of passages to read from this. In the foreword, so this is the first paragraph, the observation that hepatitis may result from injection of homologous serum after a long interval has now been confirmed beyond doubt. At the present time, transfusion with pooled dried serum appears to be the source of greatest anxiety, although comparatively small quantities of this product have been used. With greater use of transfusion in the treatment of battle casualties, pause to observe, obviously this is still during the Second World War, a corresponding increase in jaundice may be expected. The problem of serum jaundice is not only an immediate one, but may become of increasing importance as the use of dried human serum in therapeutics is developed. And then if we go down to paragraph D at the bottom of the first page, there's a discussion of the relationship between homologous serum jaundice and epidemic hepatitis, and a reference to the yellow fever vaccine jaundice investigations. And then it says this: by comparison with the estimated mortality of epidemic hepatitis, fatalities from homologous serum jaundice have been disproportionately numerous. And then if we go over the page, please, to paragraph F on page 2. There is a strong suspicion that the severity of hepatitis varies with different batches of serum. Some kill, and others produce relatively mild disease. It is also probable that serum hepatitis occurs without jaundice and that some patients may remain ambulant and uncomplaining. And then we see under the heading administrative control, and again I emphasise this is in the 1940s, although medical measures for the control of serum jaundice must wait on further knowledge concerning the nature of the jaundice-producing agent and how to remove it, much can be done in the way of prevention without this knowledge by A, avoiding unnecessary transfusion. At the present time, serum transfusion should be reserved for life-saving procedure only. B, restricting the size of pools. And then a number of other matters about records, sampling, and so on. And then, top of the next page, this is still within the list of suggested administrative preventative measures. As far as possible, transfusing any individual patient with serum from one pool only. And then G, taking greater care to exclude blood from persons suffering from hepatitis on the assumption that serum jaundice is simply transmission by unusual routes of the agent of epidemic hepatitis. And if we go to the penultimate page, please. Next page. Next page. Next page. Last but one page, please. That's it. Could we have the second paragraph highlighted, please? It is our duty to follow up and study serum jaundice, just as we should follow up any other communicable condition. Knowledge will come quickly only if the collection and collation of information is deliberate and purposeful. We should evolve a carefully proposed plan and provide adequate facilities for it to be carried out. And then we see there, Ministry of Justice, 20th of June, 1944.
I think Minister of Health.
Yes. Ministry of Health.
Yes.
And then, please, Henry, if we could have...
Just
Yes.
pausing there for a moment, so that most people will know, I think, that homologous means from human beings, as opposed to from somewhere else.
Yes. Yes, it's essentially the association between human serum and hepatitis that is the focus of all of these documents in the 1940s. We then have, please, Henry, DHSC 01408 _095. This is a letter dated the 21st of March 1945. April's been crossed out and March added. It's from, can we have the whole document? Sorry, Henry. It's from the Chief Medical Officer, W. Wilson Jameson, and it says this: Dear Panton, homologous serum jaundice, I have received reports attached that hepatitis with a high fatality is frequently following transfusion. I am concerned for the future because blood products will continue to be used in civilian practice after the war. And it would appear that the present experience amongst battle casualties provides an opportunity which is unlikely to recur for obtaining further information. The documents to which he refers, the reports, I won't bring up, but they're all in the chronology and the material that's been disclosed to core participants. And then we see, if we have, please, Henry, DHSC 01408 _105. We can see that there is then what would appear to be from the participants a fairly high-level conference held at the Ministry of Health on the 26th of March 1945. The title of the meeting or the note is Jaundice Following Transfusion. We can see present the Chief Medical Officer, a number of senior officials within the armed services, representatives of the blood transfusion services, including Dr. Panton, to whom the previous letter was addressed, and representatives of the Ministry of Health, including Dr. Bradley, who'd been the author of one of the documents that we looked at earlier. And we can see here on the first page, Sir William Jameson told the meeting that the Ministry of Health proposed to attempt to carry over into peacetime something of the transfusion arrangements that had been in operation during the war. Unfortunately, it was beginning to appear that a large number of transfused persons subsequently developed jaundice, and some died. He quoted Dr. Stock's figures culled from pensions records and death certificates. Although this serious complication might pass without comment in wartime, it would seriously handicap peacetime administration. Information concerning this puzzling condition was at present being collected independently by several persons, and he was anxious to establishment an orderly system of accumulating and using the information. And then if we could go to the third page, please, Henry. We can see halfway down the page, we just go down a bit further, thank you, the chief medical officer, summing up, said that although the accounts given were somewhat contradictory, and the accounts had been from various different military and other personnel attending the meeting, there was some reason for believing that hepatic jaundice may follow blood transfusion and that some transfused persons died of hepatic necrosis, but the position was not clear. Nothing definite had so far been learnt from laboratory work. He hoped that epidemiological study might add something useful. This required a good system of recording and a free interchange of information. And then if we go to the fourth and final page, please, Henry. Just under the heading propaganda, it was agreed that nothing which might cause public alarm or discourage transfusion in necessitous cases should be done. The chief medical officer suggested that sometimes transfusions were performed unnecessarily and that it might be wise to send some publication to institutions. Dr. Drury suggested, and it was agreed, that the opinions of regional transfusion officers on this matter should first be sought at a meeting to be held on the 5th of April 1945. And then, again, still in the 1940s, if we could go to DHSC 01408_254, please, Henry. I'm not going to go to the detail of these articles, but just to note, in terms of broadcasting to the wider medical profession what thus far has been, to some extent, conversations held internally within the Department of Health and with the armed forces. What we have here are 3 articles: homologous serum jaundice, homologous serum hepatitis, 2 cases of homologous serum jaundice. And we can see that they're printed from proceedings of the Royal Society of Medicine in August 1946. Again, without going into the detail, if we can have up on the screen, Henry, RLIT 5052, so RLIT 5052. We now have a publication in the British Medical Journal. This is September 1946. It's an article headed "The Incidence, Incubation Period and Symptomatology of Homologous Serum Jaundice" by Sperling, Schon and Vaughan. We can see here in the introduction, it says, jaundice has been recognised with increasing frequency as a sequela of transfusion with whole blood, plasma or serum, and reference is made, amongst other things, to the Ministry of Health memorandum that we've looked at. It's generally agreed that such jaundice is indistinguishable from and of the same etiology as the jaundice following the use of convalescent serum, vaccines containing human serum, and syringes contaminated with human blood. This jaundice is commonly called homologous serum jaundice. Since certain of the cases reported after transfusion have proved fatal, it appeared important to determine, if possible, the incidence of this complication, since it might well be that the risk of hepatic necrosis was greater than the risk incurred by withholding transfusion. Records of blood products issued from the northwest London area since 1940 being available, a follow-up of patients who'd received transfusions in this area was therefore instituted in 1944, with a view to determining the incidence of homologous serum jaundice following transfusion, its incubation period, and the symptomatology. The article then sets out the figures from that particular follow-up. We'll see if we look at the 3rd page. It's in relation to the findings of this report. We go right-hand column, Henry, just the paragraph above the heading summary, please. What this study found was that the character of the jaundice in the 77 cases here recorded was, with one exception, mild. It says this is in accord with the majority of other observers, but it must not be forgotten that a definite mortality after both transfusion jaundice and syringe jaundice has been noted. Also relevant to note from the 1940s still, in 1947 was the identification of higher risks associated with pooling of blood donations. And we'll go to just one document in that regard. Henry, it's RLIT 5054, please. We can see this is an American article, Homologous Serum Jaundice in Recipients of Pooled Plasma. It's published in October 1947 by Brightman and Corns. And I'll just pick it up with the first paragraph. The ready availability of pooled plasma, whether secured through commercial channels, state departments of health or local blood bank programs, has been a boon to medical practice. However, the fact that plasma may carry a virus capable of inducing hepatitis in the recipient has created a new public health problem of major importance. And if we then go on, please, Henry, to the fourth page of this document, left-hand column under the heading comment, if we scroll down. So comment, a follow-up investigation of a large series of persons who received transfusions with pooled plasma has indicated that this form of therapy carries a significant risk of a serious and possibly fatal complication, and then figures in relation to upstate New York are provided. And then if we go to the next page, please, Henry, under the heading Summary, I'll just read this. 1, follow-up of 649 patients who received transfusions with dried pooled plasma revealed a subsequent incidence of homologous serum jaundice in 4.5%. 2, the causative agent appears to be widely distributed, but the attack rate is variable. 3, the attack rate was significantly higher among persons who were 50 years of age or more. No relation of the attack rate to the amount of plasma administered could be demonstrated. 4, investigation of 51 deaths attributed to acute hepatitis revealed 15 cases in which the patients had received transfusion therapy during the 6 months prior to death. 12 of these had received plasma only. 5, 12 deaths attributable to homologous serum jaundice were reported in upstate New York during a 7-month period. And then this at 6, plasma, as well as other forms of transfusion therapy, should be administered only when the clinical indications are absolute, so that the benefits to be derived clearly outweigh the risk of contracting homologous serum jaundice. Now, turning back from America to the United Kingdom, we've now reached the 1950s. Henry, could we have DHSC 013010_405? This is a letter dated the 6th of January 1950. It's from Dr. Drummond of the Regional Transfusion Centre in Cardiff, and it's to Dr. Maycock at the Ministry of Health. And it says this: I have decided to abandon large pool plasma filtration. I do not feel I can justifiably continue to issue large pool plasma, which has an incidence of homologous serum jaundice of 10%, as opposed to 1% for small pool plasma. Were a case of homologous serum jaundice to go to the law courts and large pool plasma to be implicated, I don't think the court would be kindly disposed. It might argue we ought not to have issued large pool plasma, since the incidence of homologous serum jaundice is 10 times as great as after small pool plasma. It might be argued that the issue of large pool plasma is unjustifiable, since it is practicable to make small pool plasma either filtered or unfiltered. Such an argument would be unanswerable. Could we then please have Henry, and I'm hoping I've got the right reference here, RLIT 40215. Yes, so we can see the World Health Organization publication. This is in March 1953. The expert committee on hepatitis, set up by the World Health Organization, had met in July 1952. And I'm not proposing to go to any particular part of this document, but you'll see that by this time, hepatitis, including serum hepatitis, is, as it were, on the agenda of the World Health Organization on an international stage. And then, if we could,
I think that was the document, or at least part of the documentation, which I referred to yesterday when I was asking questions of Dr. David Owen. And for those who are interested, the passage or the principles I derived from it, are set out at Part 10, Prevention of the Spread of Hepatitis Viruses A and B by Human Blood and by its Products.
Yes. It's an important document, but and one that we will no doubt return to with some witnesses in due course. We've been in Wales with the Regional Transfusion Centre. The next document takes us to Scotland, PRSE 40157, please. This is a memorandum from the Scottish Home and Health Department, which I have a feeling I might have referred to yesterday as the Scottish Health and Home Department. 16th of December 1964, Scottish Hospital Memorandum number 89, 1964, Scottish National Blood Transfusion Association, hospital blood transfusion arrangements and the supply of blood products and clinical use. And then we'll see it's a memorandum describing the work of the Scottish Blood Transfusion Service and containing some suggestions as to the management of hospital blood banks, reminds medical officers of the risks of transfusion therapy, and gives guidance on how the risks may be reduced. That's in paragraph 1. And then if we could go, please, to the third page, Henry. Paragraph 11. The memorandum says this: all blood for transfusion must be regarded as potentially contaminated, and care must be exercised to ensure correct conditions of storage. This applies not only during storage in the blood bank, but also during transportation. And then skipping over a sentence, this: the most important transmissible disease in this country is homologous serum jaundice or serum hepatitis, the incidence of which is 5 per 1,000 recipients of blood or small pool plasma. No transfusion should be undertaken unless the benefits outweigh the risk of hepatitis. And then it says this in 12: the avoidance of transfusion accidents is primarily the responsibility of those medical officers in charge of the patient, pausing there. Whether that is intended to encompass the risk of hepatitis referred to in the previous paragraph is unclear, and of those in charge of the blood bank and laboratory, but the ramifications of the organisation of a blood transfusion service within a hospital are so widespread that it should be looked at from time to time by the medical staff committee. We're now in the 1960s, and there are a number of reported materials in the course of the 1960s onwards showing the emergence of knowledge of the Australia antigen. I'm not going to go to the majority of those documents, but it's an important part of the chronological development of the knowledge of hepatitis B. And for those who are interested, you don't need to put this up on screen, Henry, but there is an article in February 1965 which describes the emerging knowledge of the Australia surface antigen at PRSC 301518. What I want to pick up, however, is a publication in August 1965, PRSC 303897. And again, we're drawing on a range of materials to show how knowledge may have been, how risks may have been understood by different cohorts of practitioners. This is a publication called The Practitioner, and it's this particular part, Complications of Blood Transfusion, is authored by Jean Grant, the then director of the Regional Transfusion Centre in Oxford. If we could go, please, to the page 6 of this, Henry. Under the heading Transmission of Disease, we can see there what's set out under the heading homologous serum hepatitis. The development of homologous serum hepatitis is a hazard which besets rather less than 1% of recipients of whole blood or small pool plasma. And there's reference there to the MRC publication in 1954. It's caused by the transmission of a virus from a carrier donor to a susceptible patient. The donor's probably not aware that he's a carrier. He gives no history of ever having had infective hepatitis himself. And no single test or battery of liver function tests has yet been devised, which will reliably distinguish carriers of the virus from normal subjects. Then goes on to describe how recipients vary in their susceptibility. And then the next paragraph, some patients suffer no upset from the transmitted virus. Some may have only a transient liver dysfunction with or without jaundice, and yet others may develop a rapidly fatal hepatic necrosis. And then reference is made to attempts thus far not particularly satisfactory of finding a means of killing the virus in the blood. And if we go to the last page, please, of this document, and I think we can see from the way in which this last conclusion is expressed that this is intended to be advice from the Regional Transfusion Centre to practitioners in the field. Under the heading Conclusion, the practitioner should satisfy himself that it is really necessary to give blood and that no other treatment would be equally efficacious, even though it might take a little longer to achieve results. He might even benefit his patients by occasionally having the strength of mind to make the unfashionable decision not to transfuse. The hitherto healthy patient can well afford a 1-point hemorrhage without replacement. After all, as pointed out by Chassamoir, the blood donor himself lost a pint without anybody feeling that he ought therefore to receive a transfusion. And then, Henry, could we please have RLIT 40217? This is one of a number of documents authored by J. Garrett Allen in the United States. This particular publication is, I think, the 1st of April 1966. It's headed Post-Transfusion Hepatitis, a Serious Clinical Problem, and it suffices, I think, only to look at the summary on this page in italics. The risk of serum hepatitis from transfusions derived from prison and skid row populations is at least 10 times that from the use of volunteer donors. So this is being said in April 1966. For every 100 patients receiving a single transfusion, the attack rate is 0.3% where the donor is of the family or volunteer type, and 3.2% when the donor is from a prison or skid row population. The most practical methods of reducing the hazard of serum hepatitis from blood are to limit the use of blood by giving 1 transfusion instead of 2 instead of 3, etc., and especially by excluding, if possible, all prison and skid row donors. It's urged that state and federal control of the quality of blood used for blood transfusions be studied, with the possibility that measures may be taken to increase its safety. If it is necessary that blood from prison and skid row donors be used to meet the demands, such blood should be labelled as carrying a significantly increased hazard of transmitting serum hepatitis, in order that the physician prescribing blood may take the necessary precautions. And then from the US back to the UK with RLIT 301219. This is the same year, August 1966, and the relevance of this is just to show that the issue is raised in a leader in the British Medical Journal in that year under the heading Transmission of Disease by Blood Transfusion, where it says this: hepatitis, syphilis, malaria and brucellosis have all been transmitted to patients who were given whole blood or blood products. Hepatitis is by far the most serious disorder transmitted in this way. And then there is reference to the different incidence rates depending upon the size of the pool. And then it says this important hazard of blood transfusion is not as widely appreciated as it should be. And then reference is made to one reason for that possibly being the comparatively long incubation period. If we could then please have up on screen, Henry, PRSE 30821. Sorry, 40821. This is a letter dated the 5th, or there's a publication again in the British Medical Journal, 5th of November 1966, and it's a letter from Professor Zuckerman of the London School of Hygiene and Tropical Medicine. It's the left-hand column, please, Henry, the article headed, if you go further down, thank you, blood transfusion and infectious hepatitis. And Professor Zuckerman, who was based then at the London School of Hygiene and Tropical Medicine, was a leader in the field of hepatitis at this time, as we'll see from later materials. He said this: there are at present no specific tests for virus hepatitis, but the serum transaminase levels have proved a sensitive index of liver damage. These tests have not been carried out in the small series of patients reported by, and he refers back to an earlier publication, and it should be difficult to draw any valid conclusions from their results on the absence of anicteric post-transfusion hepatitis in 82 patients who received 222 pints of blood. Hazardous and misleading to attempt to translate these results into national figures. Estimates of the risk of hepatitis in blood recipients in the USA vary from 0.3 to 4.13%, and from a number of reports it was estimated that the overall mortality from post-transfusion hepatitis could be as high as 27.5%. Even more significant is the fact that although infectious hepatitis cannot be considered a major cause of death, it nevertheless ranked in 1959 in the USA second only to influenza among the deaths attributed to acute virus infections. And then if we could go to the top of the next column, please, Henry. In this country, an estimate of the size of the problem of hepatitis cannot be made, since hepatitis is not notifiable on a national basis. Nevertheless, it should be a matter for considerable anxiety that there are indications that the number of deaths from hepatitis after cardiac surgery in some centres exceeds the mortality from surgery. Therefore, before we can aspire to undertake any preventive measures, the first step should be the notification of hepatitis and the establishment of a follow-up system for all patients who have received blood transfusion. The problem is surely of such importance as to preclude any attempts to guess the actual figures for hepatitis. So that's Professor Zuckerman in the mid-1960s recommending the establishment of a follow-up system for all patients receiving blood transfusion. There's a further document from Professor Zuckerman Henry at Arlit 40220. You don't have that? Don't worry. We can come back to that if need be. Can we then go to PRSE 303714? So this is September 1969, an article in the British Medical Journal, or a letter in the British Medical Journal, from the Royal Infirmary in Liverpool, headed Serum Hepatitis in a Haemophiliac. It says this: serum hepatitis after the use of cryoprecipitated anti-haemophilic globulin is unusual, refers to a reported case, and then says, we report a second case with a fatal outcome. The letter then details the particular case, which I won't take time going through. But if we go to the concluding two paragraphs of the letter, it says this. Henry, sorry, if you could go back up. That's great. The clinical and necroscopy findings here are fully compatible with the diagnosis of serum hepatitis. Cryo represents a considerable advance in the management of the severe haemophiliac. This and other centres have used many thousands of units without mishap, and we do not know of a similar case in Britain. It is important to re-emphasise the potential danger of cryo to ensure its use only when strictly needed. A check should be kept of the source of cryo to trace any serum hepatitis which may occur in the future. And I'm not going to go to it, but there is then in the British Medical Journal 2 months later, November 1969, another case of serum hepatitis in a haemophiliac patient reported in Belfast. And the reference for those who are interested is PRSE 304488. So that brings me to the 1970s, and the next document is one that might take a little longer to look at. So is that a convenient moment to break?
Yes, it is. So we'll take our break now for the next 45 minutes and be back at 22:12.